Test 1 2 1 2. Test 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 test.
This is the most awkward presentation I've ever done when everybody is over there. So, okay, but they're telling me I have to stand right here. Are you all ready, technical guy? Tech guy, are you ready? Is everything going?
Talk to her.
No, but you're the streamer.
She works here. She controls this.
Okay. All right. I can start, right? Okay. Way too fancy for me. Hi, I'm Ron Hirsch. I'm a physician with R1. We help Ascension hospitals with their level of care determinations. I'm based out of Chicago. And this afternoon, actually, I'm supposed to fly to Oregon, but it's snowing in Denver. So my flights are all delayed. How about that? So thanks for having me here before the humidity gets here. It's actually quite nice. So we're going to talk about observation and extended observation. I guess we can take questions as we go. I'll repeat them for the people who are on the live stream or wherever else they are. I do like it to be interactive. I don't want to just sit up here and lecture people. I like to walk, but they're not letting me, so I'm sorry about that. So we're going to talk about some of the nuances of this stuff. So the first thing is that we want to make sure when we put patients in a bed who are staying that we get them in the right status. Right? If we can get the right status up front, we can save ourselves a lot of phone calls, a lot of chasing doctors down, a lot of confusion. I want doctors to be great at medicine. I want them to take good care of patients, to order the right medications, communicate with their patients. I don't want them to spend too much effort and time on the regulatory stuff and trying to figure out status. It's not worth their effort. And the harder they try to understand it, the more likely is that the rules are going to change as soon as they master it. And we see that happening all the time. So it's important to understand that when we take care of patients, so we call some inpatient and we call some observation or outpatient, they're getting the care they need, right? Status has nothing to do with the care we need. The patient needs. They shouldn't be choosing antibiotics, choosing surgical types, picking the implants based on the patient's status or their insurance company, right? So it's really just it's a way for the hospital to get paid properly. It's unfortunate that we have to do all this stuff, but that's the way it is. I mean, it's really all started to give the basic history is that Medicare is funded with two sources. There's a Part A and a Part B. And they're really separate buckets of money that can't be combined. So Medicare had to create this outpatient observation thing to be able to finance patients who have short stays in the hospital, which is different than the patients who are staying longer in the hospital. Right? We're also faced with a country where there's a multiplicity of insurance companies. And every insurance company really gets to come up with their own regulations, their own rules about status. So I like to teach the Medicare regulations because your CEO does not want to go to prison. Right? And if I teach you Aetna's rule or Blue Cross rule and you start applying that to your Medicare patients and you get a bunch of denials and you get the Office of Inspector General coming in, it doesn't turn out well. Right? We also know that the insurance companies, which includes Medicare Advantage, Managed Medicaid, the regular Medicaid, they kind of make up their own rules as they go along. And your case managers or you, our staff, will tell you, one day they talk to Blue Cross and they want this set of rules, and the next day or the next hour, the rules change. So it's really hard to follow along. Medicare, we know the rules, we know how to follow them, and we know the consequences. It also notes that patients can't dictate their own status. Right? They often read things in AARP or on NBC News or wherever that tell them that they should demand to be put in a special status. It's wrong. They can't do that. Right? They cannot demand anything more than they can demand for you to do a surgery or give them a medication that they don't need to have done. So we want to talk to them. We want to explain why we have to follow the rules, but we can't do what they want just because they want it. Right? The other thing that's important to understand is that we really don't care about what the status is called. The hospital really cares about how much we're going to get paid for taking care of that patient. And an example here is what's happening with some of the joint replacement surgeries. We're finding out that in some cases, some of the old insurance companies still have contracts where they pay a percentage of charges. And we all know that hospital charges, which are now in the news all the time, are outrageously high. But if you're a hospital that's getting paid a percentage of charges on an old contract, and that percent of charges for your outpatient pays you better than inpatient, why are we going to insist on admitting the patient as an inpatient? Right? If it's the same care and we're going to get more money, let's keep them outpatient. Likewise with medical patients, if we're getting paid per day from an insurance company, if it's an outpatient stay, and we're going to end up with more money than if we admit them as an inpatient, why don't we leave them outpatient if that's what the insurance company wants us to do? So we have to remember, it's hard to sometimes come up with these numbers, and the finance people don't like to share this stuff. But oftentimes, by insisting on admission, for some insurance companies, we're actually insisting on losing or getting less money. Right? From the patient side of things, we want to look at the costs, because again, this is an issue they often bring up to us. So if they're placed observation and they're Medicare, right? Medicare is going to pay the hospital for that observation stay $2,106. The patient is going to owe their once a year Part B deductible of $183, and then they're going to owe 20% of that $2,106. So that's obviously $420. Right? Then if you charge for medications, any of their self-administered meds, they would have to pay for those. So maybe if they take a bunch of pills, you charge them $400 for their medicine. So we add that up, that's $820 to be an outpatient observation under Medicare. If we admit them as an inpatient, the minute they get admitted, they owe their Part A deductible. And that Part A deductible is $1,364. Now it does reset after 60 days, and there's a whole bunch of nuances to that. But in essence, if they're asking to be admitted as an inpatient, they're asking to pay more money. And that really makes no sense. Right? Again, they heard it somewhere, they read it somewhere. It's wrong. So remember that. So this whole thing about OBS versus inpatient really goes down to the 2 midnight rule, which is now almost 5.5 years old. And Medicare decided to draw a line, try and avoid all the confusion by saying patients who are expected to need less than 2 midnights should be treated as outpatient, and those who are expected to need more than 2 midnights should be inpatient. So we need to decide at the time we're making the decision, how long is the patient expected to need in the hospital? Right? It's a good estimate based on what they're presenting with, what we're planning to do for them, and how long that's going to take. Right? So our first step really is to decide if they even need to be in the hospital. Right? So there's lots of people who come into the emergency department or seek care that actually don't need to be in the hospital. Right? They can be sent home from the ED. They didn't even need to come in. Right? Maybe they don't have a nice living situation, but they have to require hospital care for us to move on to step 2. Right? Patients who are not safe at home don't need to be in a hospital. Right? They need to be somewhere, not a hospital. So we can't admit those patients as an inpatient. When we're looking at this 2 midnight thing, we have to look at when the patient presents and when we start their symptom-related care. So we're used to looking at registration time, time of the admission order, time the ED doc sees the patient. Those actually aren't important for this 2 midnight determination. It's when we start their care in the ED related to one of their symptoms that brought them in. So if they come in with chest pain, they're going to have an EKG done hopefully within minutes, and that's going to start our clock. They come in with abdominal pain, and the ED nurses have a protocol that says anybody with abdominal pain, we should do a CBC, lipase, send them for a CAT scan, or whatever the protocol says. That would start our 2 midnight clock ticking. So if we decide they need hospital care and we look and we think that they're going to need under 2 midnights, we're going to put them in as observation. Those patients generally fall into 3 categories. It's a patient who had some kind of scary symptom at home or somewhere else. They're feeling fine now, but they need some testing to make sure they're not going to die. And that tends to be your chest pain, your TIA, and your syncope patients. If everything's negative, we should get that done in 1 day, and they should go home. If it's abnormal, then we would keep them. Right? Patients with a minor illness that needs treatment are the second class. So they're going to be treated. They don't look so bad. We think maybe they'll get better by the next day. We don't know how long it's going to take. We're going to start them in OBS and see what happens. And then the third group are those who have a symptom that's ongoing. We don't know what's causing the symptom, so we're going to get some diagnostic testing and treat their symptom. Right? So if we don't know what's causing the symptom, we can't possibly know how long they're going to need in the hospital. And if we don't know how long they're going to need, we start them in OBS and we see what happens. Right? The reality is, in most parts of the country, the people on the bottom with pain really just have a dilaudid serum deficiency. And once we correct them, they're able to go home. But we don't know how long it's going to take, so we start off and we do some tests. Okay? If they're sick, we think they're going to be here for 2 more midnights, we make them an inpatient. The key is the documentation. The H&P must explain how sick they are. It can't just be UTI, admit as inpatient, because that doesn't tell us why they need to be in a hospital and why we need that they're going to need more than 2 days in the hospital. Right? We want an H&P that someone else reads that impression and plan and says, yeah, this is a sick patient. They are not going home tomorrow. Again, if we don't know what's going on, we're going to put them in OBS, get some tests, decide the next day what happens. Now, a lot of people, when they hear this, say, but this kind of takes away the whole physician judgment thing. You're telling me what to do. Well, your judgment as a physician still matters, because you can look at a patient like this guy, an 83-year-old coming in with hypertension and heart failure, who has shortness of breath and weight gain. Ran out of his meds. He's eating a lot of ramen noodles. His blood pressure is 104, heart rate's 100, respiratory rate's 22, pulse ox 91. So not too bad, right? He's got some edema. His BNP's 800, creatinine's 2.3. Troponin negative, D-dimer negative, EKG's unchanged, and chest X-ray with congestion. Right? So at face value, you'd say, oh, that's OBS, right? Just some heart failure. He stopped his meds. He just needs some diuresis. Well, that would be the easy thing to do. But if the physician looks at the patient and says, this guy, he's fragile, right? I'm not going to blast him with Lasix and diurese him, because last time they did that 6 months ago, he ended up with acute kidney injury. He ended up staying for 5 days, right? We were chasing fluids and diuresis back and forth. So if the doctor uses their judgment and documents that the elevated creatinine with exacerbation requires careful diuresis and monitoring over several days, we can make them an inpatient from the beginning. So that physician judgment means a lot. Right? The key is it has to be documented. Right? The auditors, the reviewers, the insurers can't read your mind to know that you're concerned about the creatinine, you're concerned about overdiuresis, you don't want to send them an acute kidney injury, etc. Right? Now, we can be wrong with all this stuff. So we put somebody in observation, we check on them the next day, and they're still sick and they still require ongoing hospital care. Medicare says if you put them in OBS and they need a second midnight, you admit them. Now they become an inpatient. Right? They become an inpatient, and you document why they need to stay in the hospital. The asthmatic or COPD patient didn't look too bad. You put them on some nebs and steroids. The next day they're still wheezing. Gonna stay, admit. Right? The old guy who came in with a little bit of rectal bleeding, and you kind of scoffed, this is no big deal, he'll be fine tomorrow. But you kept him on OBS. The next day his hemoglobin drops 4 points. Well, now that something's going on, we've got to admit him as an inpatient because we're keeping him. Right? So if they need a second midnight, we admit. Now, when we talk to docs about this, they often say, but why would I admit him? Because he's going to go home tomorrow. Right? I'm not going to admit him just for 1 day. Well, Medicare says absolutely. If they need a second midnight, you admit them. Because if you get to tomorrow and they didn't clear up like you thought they would, then you're playing the game again. Oh, but now I'm going to keep them 1 more day, and since it's only 1 more day, I'll keep them in OBS again. So we don't want to do that. If they need a second midnight, we always admit them. Right? The other thing we hear from physicians is, I don't feel comfortable sending them home. Right? And when I did an ICD-10 search on discomfort, I found no clue, no code for physician discomfort. So we can't code that, we can't use it. What we need to know, though, is what is the physician uncomfortable about? Right? What's the lab value? What's the finding? Why can't they go home and see their doctor in the office in the morning? Right? Show up at the lab at 7, get a CBC, and go see a doctor to follow up on it. Right? What is it that's keeping them? Right? If we document that, it makes sense. We can make them an inpatient for that second midnight. Now, we also have to watch, again, this time that the care starts, because that can make a difference. So here's a patient who comes in at 4 a.m. with some dyspnea. He's got COPD. Vitals don't look too bad. He's a little dyspneic. He's got some wheezing. So the ED does their stuff, and 2 hours later calls the hospitalist because they're still wheezing. Right? So they need to be hospitalized. The hospitalist checks the patient at 7, recommends hospitalization, thinks he'll get out by tomorrow, so they put him in observation. Right? It's pretty easy. Right? Vitals weren't bad. A day of nebs and some steroids maybe will do the trick. Right? What if this patient, though, started their care at 11 p.m.? So that's when they came in the ED, and at 11:15, the nurse in triage gave the patient a nebulizer, because that's per their protocol. Right? So the ED doc does their stuff, and at 5 o'clock, the patient's still wheezing, so they call the hospitalist. Hospitalist gets down there at 7 a.m. Of course, the night hospitalist stretches things out, so the daytime doctor comes in at 7 and has to take the new patient. They get in at 7, they look at the patient, and they say, yeah, this guy doesn't look so bad. He's already had 6 hours of steroids, but he's already spent 1 midnight in the hospital, right? Because his care started at 11:15 at night. So since his care started at 11:15, I'm going to put him in OBS, but I'm going to check him in late afternoon. And if he's still short of breath in the afternoon and he needs a second midnight, I'm going to admit him as an inpatient. So because this patient's care started before midnight, 11:15, as opposed to this guy who came in at 4 a.m., same symptoms, same care plan, but different time of care began, makes a difference in the admission status. Right? So we really have to make sure we watch when that time their care started. Now, with every Medicare rule, unfortunately, there's exceptions. So I kept saying always admit, always admit. The exception is we don't get to count convenience days. So if the patient's staying another midnight because of somebody's convenience, either the patient, the hospital, or the doctor, we don't get to count it. So if you have a Saturday chest pain and you need a stress test on Sunday and you can't get it, they're going to stay a second midnight, but that's a convenience to the hospital that we're keeping them a second midnight. We should be able to get stress tests on Sunday, right? It's a hospital, right? If we're not going to do stuff on weekends, shouldn't we just close the whole building and everybody comes back Monday morning? I think, right? We can't let people sit around and not offer services every day. So we're going to leave a patient observation for a second midnight. We're going to try and keep track of those things so we can figure out where the delays are and decide if we want to fix them. There's also patients who don't like to go home. They like hospitals. They like the food. They like the attention. And in those cases, if patients staying because they want to stay, but there's no medical necessity, we can't admit them as an inpatient for that second midnight. Right? Theoretically, we should get them home. Let's figure out how to do that. Call an Uber, call their family. Make sure the family knows the day before when they're leaving so they can be there to give them a ride home. Right? Just because it's raining doesn't mean you can't drive home. Right? Those days, again, if we're going to let somebody stay, we leave them observation for that second midnight. Okay? So again, if there's no delays in care, no observation, patient should ever pass the second midnight in observation. We either admit them or we send them home. Right? If there's delays, it could pass the second midnight, but again, we want to keep track of those and figure out where they are and decide how to fix them. Right? I don't know whether you guys board people in the ED if you get busy where you have bed shortages, but a lot of hospitals have that problem where there's people sitting in the ED, in gurneys, in the hallway, waiting for beds upstairs to open up. And you go upstairs and you find people sitting around who should be going home but aren't because of some delay in care. Right? It's not fair that the patient in the ED has to sit on a stretcher in a hallway using a bedpan when there's someone upstairs who's staying just because it got dark and they can't drive home. We have to remember that. Right? What we're starting to see a little bit of movement around the country is that there's no rule that says that patients waiting for beds have to stay in the ED hallways. So some hospitals are actually putting those boarding patients in the hallways upstairs. Right? When suddenly the upstairs staff has extra patients in their hallway to take care of, they find there's ways to get patients out quicker. So we'll see if that becomes an issue. There's also these patients who come in as social admissions. Right? And social admission is a bad term because they never should be admitted as an inpatient. They're being hospitalized because there's no place else for them to go. They were found in squalor, the family dropped them off on the way to Florida, whatever else it is. But we can't admit them as an inpatient because they have no medical necessity for care. Right? We oftentimes will put them in as OBS for one day, just to kind of look for a UTI, give them some fluids, see if there's something reversible. But after that, it's really just custodial care. We're babysitting them until we can figure out what to do with them. So those patients are going to stay outpatient. Right? We may leave them in observation status because that's just an easy way for the computer to assign them a bed. But they're going to be extended observation really for as long as they stay until we can figure out what to do with them, or until they inevitably get sick. Right? Their IV gets infiltrated, they get fever, something happens to them that makes them now worthy of admission. Right? If there's any revenue people in the room, when we're billing these extended observation patients, we need to carve out those hours. Right? So we have to tell Medicare that we're providing unnecessary care to a patient so they don't pay us for it. And we don't get credit on our cost reporting. Right? It's a fancy terminology, you know, but it's up there if you need to know how to do the revenue codes and the HCPCS codes. The other option, by the way, which I hadn't mentioned, is that we can give patients an advanced beneficiary notice. Right? So if the patient doesn't want to leave the hospital and everybody thinks they're ready to go home from observation, there's a form and we can charge them observation hourly rate to stay in the hospital. So, you know, Mrs. Smith, you're welcome to stay here. The doctors think you're stable to go home. If you'd like to stay, here's a form, and we're going to charge you $250 an hour to stay in Hotel St. Vincent. Okay? Most times patients are able to find a ride home if they suddenly realize that they're going to have to pay. And by the way, if they sign the form, you then call your finance people, your registration people, to come up and scan their credit card or do something to actually start the payment process, because they become eligible to pay the minute they sign that form. Right? A better option is a lot of hospitals with these patients who don't even need to be in the hospital at all is to come up with an ED SWAT team. Right? Just like SWAT teams with the police plan for disasters and plan for things to happen, why don't we plan for these patients who we know are going to show up Saturday night or early Sunday morning? So let's get everybody together and figure out what can we do with a patient who shows up Sunday morning and the family's going to take off for Florida. Well, we have a nursing home in our group that is willing to take them for a low rate, for a daily rate, till the family can come back. Or we have senior services that knows the laws about elder abuse and elder abandonment that we can call right away to talk to the family about how their obligation is to take care of their loved ones. Right? Involve all these people and plan for those patients who show up. The other thing we want to do is when the patient comes in and the family comes in with them, we want to put them in the room and we want to lock them all in the room. Right? Because once the family leaves, it's all over with. Right? So do that. All right. Now, we often hear from hospitals that we have too many observation patients. Right? And unfortunately, this comes down from usually an edict from above that we have to reduce our observation rate. The problem is we don't always know what's causing a high observation rate. Right now, excuse me, while the insurance companies, the way they work is they kind of tell us the status for the patients. Blue Cross, Aetna, United Healthcare, they kind of set the rules. So if they're avoiding it, allowing you to admit patients as inpatient, you're going to have a lot of observation patients because your Medicare Advantage plans like observation. Right? You can't control that. Right? That's out of your hands. That's contracting. Right? What about the OBS patients, as we talked about? If you have patients in OBS and we let them stay past the second midnight, they should have been admitted, we're going to have patients sitting in OBS that should have been in. Right? Loss of revenue, higher OBS rate. So we want to make sure every over 2 midnight OBS patient gets reviewed. Right? Whoever's coming up with this rate, where are they getting the number from? Right? If you go to your finance people and ask them what your OBS rate is, and then you go to your case management people and ask what the OBS rate is, I guarantee you the numbers will be nothing alike. Right? Because they have different systems and they come up with different numerators, different denominators. Right? Finance doesn't know to separate Medicare from Medicare Advantage. They think it's all Medicare. Right? Then you get the Medicaid in there. So if we're not measuring apples and apples, we're never going to come up with the right number. Right? And another problem we're having is that if you have a high observation rate, it's not because you're not admitting enough people, it's because we're putting people in OBS who probably could have gone home from the ED. And I know this is it's a little touchy subject, but ED doctors are getting this pressure for throughput. Right? It's one of these publicly reported measures. How long do patients sit in the ED before they're either admitted or hospitalized or sent home? So there's always this clock running in the ED department or in the ED that if patients have to be dispositioned within 2 or 3 hours, right? So the asthmatic who probably could use another couple nebulizers and maybe would get better and maybe be able to go home, now they pull the trigger on putting them in OBS so they don't get dinged for having a long throughput time. So we're hospitalizing people who don't even need to be in the hospital, and that's giving us a higher observation rate. So the rule is, if every patient is reviewed by case management and get put in the proper status, everyone's in the right status, observation is ordered only on the right patients, so we're not ordering on surgery patients, we're not doing it on patients who are here for courtesy stays. Right? Every patient goes home when their care is finished, and if you have medical necessity for second midnight, you get admitted, then your OBS rate is where it's going to be. There is no benchmark. There's no national standard. Every hospital is going to be different. Excuse me. So now what about surgery? Well, surgery is a whole different world because surgeons are a whole different breed of people. Right? They have their special kind of rules, and they do amazing things in the OR. Because it's a lot more expensive, a lot more intricate, they have a whole, Medicare came up with a whole different set of things. So for non-Medicare, of course, with surgery, we're always going to call the payer and figure out what the status should be. For Medicare, we don't have anybody we can call, so we have to go by the regs they give us. And they have something called an inpatient-only list for Medicare. And so there's an inpatient only, and then there's non-inpatient only. Right? For inpatient only, just like it sounds for Medicare, it has to be inpatient. Doesn't matter how long the patient's going to stay, doesn't matter what the recovery is. If they're inpatient only, they get it done. They can go home the same day, they can go home the next day. There's no 2 midnight rule at all for those patients. Right? If it's not inpatient only, it's generally outpatient unless there's some factors that would change it from outpatient. So the factors we want to look at is what's the surgery, what's the patient, or who's the patient, are they already in the hospital, right? And the time of day and number of midnights. So we can take outpatient surgeries and we can make them observation or inpatient depending on the circumstances. So if the patient's already in the hospital and they're going to get an outpatient or non-inpatient only surgery, the first thing we want to check is to make sure the surgery is necessary while they're in the hospital. Now I know this sounds a little strange, but if someone's coming in with pneumonia and now they're being scheduled for a cholecystectomy or a TURP, someone needs to look and figure out, why are we doing a cholecystectomy on a pneumonia patient, right? Maybe it turns out it wasn't pneumonia. It was just, we thought it was a right lower lobe pneumonia, and it actually was acute cholecystitis, right? Maybe it was that they're here for pneumonia, and they mentioned that they're having trouble peeing, so the doctor called the urologist, and now the urologist is scheduling a TURP, right? Now, the cholecystectomy, absolutely we need, but the TURP, that patient could certainly wait, right? And Medicare watches those things, and they audit those really heavily. So we have to be careful when patients are having surgery who come in with a medical diagnosis. Right? But if they're coming in, they need the surgery, then we're going to apply the 2 midnight rule. So here's a patient who came in the ED at 10 p.m. with abdominal pain, had some vomiting and had some blood. So they put him in observation because they didn't know what the pain was from. They got an EGD which didn't show anything. They did an ultrasound, showed cholecystitis. So now they're going to go for a lap chole. Okay? So they started their care at 10 p.m. We're on the next day at 6 p.m. and they're going to go to surgery. Right? Since they're going to surgery at 6 p.m., their standard recovery is going to take them past the second midnight. Since they're passing the second midnight, we can make them an inpatient. For Medicare, this would be an inpatient. Now, with Blue Cross Retina, we call them, they're going to want you to keep it outpatient. But for Medicare, we can make them an inpatient. Again, same rule. If they're going to pass the second midnight, it's medically necessary, we can do that. Here's an 87-year-old female having a hysterectomy for stage 1 cancer. Right? Elective surgery. Right? She had some bleeding, went to a gynecologist, she's going for surgery. If I came in for a hysterectomy, I'd be in and out the next day. She, on the other hand, has COPD, diabetes, arthritis. She sees her pulmonologist and they're ordering nebulizers and steroids. What are the chances of her getting out the next day? 0. So because of her unique circumstances, we can make her an inpatient for a normally outpatient surgery. And the reason we want to do this right away is so we can start her counting for the nursing home. Because we know after 3 days, there's no way, or 4 days even, she's going to be up and walking in the halls and doing great. Right? She's probably going to need a nursing home for rehabilitation. So we still have that stupid 3-day rule for nursing home. We can start the clock counting on the day of her surgery, and as soon as she's ready, she'll be able to go to the nursing facility. Right? So individual circumstances can make a difference. Again, the key is documentation, by the way. Right? We can't just say old lady going to need several days. We need to know why it's special. Right? With outpatient surgeries, we have to look at how long they're going to stay in routine recovery. So Medicare pays for the surgery and for the routine recovery as one bundled payment. Right? And we can't start observation if they're still in routine recovery. Now, when routine recovery rules came out, Medicare put this thing in here it says EG 4 to 6 hours, and it threw everybody off because they thought that's what routine recovery is for every surgery. Well, that's not true. Routine recovery is really what the surgeon says routine recovery is for that surgery, for the routine patient. So it could be 2 hours if they're doing a hernia. It could be overnight if they're doing a mastectomy. The surgeon really sets their normal recovery at what they are comfortable doing. Right? So if they're spending that night as part of routine recovery, because that's the way the surgeon does it and that's the standard of care, that patient's going to stay outpatient overnight. I don't know what you call it here, but various places call it a bedded outpatient, extended recovery, outpatient in a bed. There's all kinds of terminology. It's part of the surgical package. It's included in the payment. We want to make sure it's appropriate for the patient and that we're following really the standard of care. Once in a while, we come across surgeons who have been practicing a long time, who learned things a long time ago and were comfortable with the practice so they continue it. So I've seen urologists who learned to do TURPs and kept people on bladder irrigation for 2 days. Right? That patient's going to pass the second midnight, right? But that's not really medically necessary in 2019. TURPs now get bladder irrigation overnight and go home the next day. So we're going to keep that doctor's patients for 2 days in routine recovery. We can't admit them because they need a second midnight because the doctor's practicing older medicine and hasn't really kept up with the trends. But we can order observation if that routine recovery ends. And it can end for 2 reasons. One is that we've gone through the planned period and the patient's not able to go home. Or we're in the routine recovery and something unexpected happens that requires more care. So what kind of things? Well, it's the whole list of what can happen to a patient recovering from surgery. Nausea, vomiting, pain, dysrhythmias, psychotics, mental status changes, reactions to medicines, etc. Right? So how does this work? If the care deviates from your routine recovery due to a complication like hypotension or bleeding or arrhythmia or hypoglycemia, we can get an order for observation at that point. We're no longer doing routine recovery, we're now doing extraordinary recovery. So we need to know what it is, document it, get the order for observation. Right? If they're gone through their normal recovery, they're supposed to go home, but we're at that point and they can't go home because they're still in pain, still requiring IV medications. Right? They're not eating well. Right? They're not walking like they should be. They're not peeing. Right? Their mental status is abnormal. They've got a fever. Whatever it is, the doctor says they can't go home. We need to watch them longer. We can put them in observation. Right? And once again, we want documentation about why they're not going home. So the most common is the lap chole who spends the night. Next morning, the surgeon rounds and the patient is still getting IV pain medication. They're still not eating. So they want to watch them till dinner time. We can order observation, watch them till dinner, reassess at dinner time. When it gets to dinner time, or right prior to that second day, if the patient is going to stay in the hospital because they require continued care, at that point we're going to go ahead and make them an inpatient. So just like our other thing, if we put them in OBS, they get to a second midnight, they need additional care, we make them an inpatient. Right? If at any point during this recovery something really bad happens, of course we can always admit them. So the patient had a surgery, they're in a recovery room, they develop chest pain and their EKG changes. Now that they're having an MI, we're going to make them an inpatient right away. Right? Develop ileus, they get an NG tube, they're not going home 4 hours later. We can make them an inpatient. So again, we're going to look at the severity of their illness and decide how bad it is and whether they're going to be an inpatient or an observation. Right? And of course, we're going to have patients who end their routine recovery and they don't want to go home. Right? They drank well, they're eating well, they can't get a ride, they want to stay. We don't get to admit those patients. So here's an 87-year-old who has a hernia repair. He's supposed to stay 3 hours and then go home. If he's drinking well, after 3 hours he's still nauseous. So the doctor orders observation due to nausea, orders some IV fluids. We're going to bill the OBS hours. Right? The next day, surgeon comes in and now the patient's distended, their pain is worse, diagnoses an ileus, right? Puts him NPO, not going home, right? Admission. So this patient now gets admitted as an inpatient for an ileus after their hernia repair. Okay? I don't want you to do things because of the money, but just so you understand the finances, a hernia repair probably pays the hospital $3,500. If we get the admission order for the second midnight and it's appropriate, the payment goes up to $12,000 to $15,000. Because when we admit them at the second midnight, they may stay 1 more day, they may stay 5 more days. Right? They may have to go back to the OR. All kinds of things could happen. So that's how the DRG system works. But if we leave them in outpatient for that second midnight and they go home the next day, we've just lost $10,000 by not getting 3 words, admit as inpatient, when Medicare wants us to. Now again, what if this guy on day 2, the surgeon gave him fluids overnight, rounds on him in the morning. In the morning he's doing a little better, but he wants to watch him till dinner. So we leave him in OBS till dinner. Dinner time he's doing fine, but his wife doesn't drive in the dark because she's got macular degeneration. Right? So we're going to keep him in extra midnight. We're going to leave him in outpatient if we do. We're not going to get any extra money for it. We eat the cost. Here's a guy who has a hernia repair post-operatively where he's supposed to have the 3 hours, but at hour 3 he starts wheezing. So now we call the hospitalist who sees him and, it's an asthmatic, right? And we need to start ordering nebulizers and monitor his asthma. After we put him in OBS, the next day he's still short of breath and now his pulse ox is dropping. So now he's going to stay a second midnight. Now we have to admit him as an inpatient, right? In this case, we're admitting as an inpatient for a medical reason that's unrelated to the surgery. That's okay. Right? He needs to stay in the hospital. Right? The payment here actually is quite generous. So if you have an medical admission after it's outpatient surgery, it can pay up into the $20,000 range. Right? Because again, we don't know how long he's going to stay. We don't know what care he's going to need. But that's the way the Medicare DRG system works. I don't know if you're in any bundled payment programs. Does anyone know bundled payments? All right, no one's saying it. Okay, so I won't explain it. There's some nuances to the way Medicare is trying to move from volume to value with the bundled payment programs that make some of these admissions a little bit wacky. So eventually we're all probably going to get there. Medicare keeps experimenting, trying to figure out the best way to do it. The most important thing, again, with even the bundles, is to make sure everything is documented well, everything is justified, so we know why every patient's in the hospital, what we're doing for them, and why they need to stay a second midnight. So that's observation, extended observation, a little bit about inpatient, questions, concerns. I usually get someone saying, but Aetna makes us keep people in observation for 4 or 5 days. And again, the answer is that they get to do that because we let them. They can make their own rules, and we just have to follow along. Yes, thank you.
And these determinations of trying to decide, later in the day, whether the patient's going to stay overnight, this calls for more intensive physician monitoring of the patient, more visits. How does that impact physicians and hospitals, or I guess hospitalists, whatever?
Sure. So the question is that if now we have to evaluate all these patients before the second midnight as a physician, you saw them in the morning and now you got to check them on the afternoon, how does it affect physician reimbursement? Well, from the physician reimbursement side, if you can combine your 2 visits and increase your code level, if you have the documentation there. The reality is, in a lot of places, the physician may have seen the patient in the morning. By afternoon, the UR nurse, somebody on the floor, has realized we have this OBS patient. They're approaching the second midnight. They're not going home. They would call the physician and say, Dr. Smith, your patient is still wheezing. Do you want to keep her till tomorrow? You would say yes, and the case manager would say, okay, I'm going to put an admission order in your name that you'll need to co-sign. Is that okay? And you would give your okay, hopefully. And so for you, it would really just be a telephone call and then a co-signature of an order.
So you're not charging for multiple visits in one day, you're combining and expanding.
Right. Medicare will not allow a physician to bill for 2 visits in one day, unless it's a critical care visit. So you have to combine them. Yeah. You're all masters. All right. Well, I don't know if do streamers have question things? I guess not. I still can't figure out who he is.
Sometimes it comes up.
Yes.
The patient there, 10 minutes to 12, and you know that you could actually initiate the proper treatment that would trigger that 24-hour.
Yep.
I mean, we don't really want to game the system, but how should we think on behalf of the hospital whether to push to have the EKG done before midnight or after midnight?
It's not gaming the system for a case manager or somebody in the ED to go in the waiting room at 11:30 at night, figure out who's waiting to be seen, and if anyone looks sick enough, start their care before midnight. Absolutely.
Is that a benefit to the hospital?
Absolutely. Like our COPD guy, if you can get the care started before midnight, the 11:55 p.m. start of care is going to balance the person that strolls in at 12:02 a.m. and you can't get the first midnight for 24 hours. Right? Now you have to remember, if a patient's sitting in the waiting room and there's a chance that they may need to be hospitalized, they probably shouldn't be sitting in the waiting room. Right? So it's good care to make sure their care is started. Someone's assessed them beyond just a simple registration. So it's not really gaming.
And you were saying that
Yes. But we can't keep them in OBS to make it less for the patient, because that also is non-compliant. I mean, you're right. Theoretically, you could leave them in OBS for 5 days. The patient would only owe $800. But eventually, you'd have no place to work because the hospital would go bankrupt. And they all want to get their paychecks. So you do have to balance it. The most important thing really is keeping patients informed. And now they get, if they're in OBS, they get this MOON, a Medicare Outpatient Observation Notice that tells them about their payment. If they get admitted, they get the important message from Medicare. It really falls where it does. Yes?
For extended observation, when the physician continues to check on that patient, does the patient not pay additional fees for the physician charges? So, and if that's the case, wouldn't their payment go up in
So-
an extended observation?
So if they're in extended observation, they're getting more physician visits, they may have additional charges. But physician visits are always under Part B, whether they're an inpatient or an outpatient. So again, that might be a matter of a couple dollars, but it still shouldn't make a difference. We want to do its best. And we have to remember, hospitals are dangerous places, right? You know, we shouldn't be leaving people sitting in overnight who don't need to be here as much as they want to, because they're going to get MRSA or C. diff or something happen to them, the wrong pills. Okay, well, thanks for your attention. I appreciate it.